Okay, everyone, thanks for joining. Really appreciate it. And thanks to both of you here as well. So we are going to have a little chat about ventilator-associated pneumonia. And all of you will have perhaps seen this before. I know adult trainees and PICU, PEDS trainees in the NICU. It's a problem across all spectrum of patients that require a prolonged mechanical ventilation. So, and yet it is one of those things that is a great clinical challenge in terms of actually deciding it is happening. And therefore, it is one of those situations where we have a low threshold to treat, and therefore it contributes to high use of antimicrobials in the PICU setting. I know it does in the ICU setting as well, but we're just going to focus on PICU for this case. So what does that mean? Well, it means that from our data, from our hospital's data, we know that VAP, VAP is defined as a pneumonia that occurs 48 hours or more after onset of mechanical ventilation. And we know that in general, in that patient cohort, the sort of median length of mechanical ventilation is around 6 days. But in those who go on to develop VAP, it's around 12 days. So it significantly increases your duration of ventilation, increases mortality, obviously increases risks of other long-term complications, and obviously an economic burden, as well as how it contributes to antimicrobial use. I'm just going to try and minimize my face. Let's get rid of that. Okay, so there is already a high antimicrobial use in the PICU setting. So we know that patients that come into PICU end up on antibiotics for 2/3 of the time they're with us. And around 6,000 admissions a year come in for a respiratory diagnosis. In total, about 18,000 a year come into PICU for across the UK. VAP prevalence in the UK, I mean, this is an area of research, interestingly, so have tried to dig into the data. It's really not well documented or defined in the UK setting. And as you likely know, diagnostic yield is very low. And there's two reasons for this. One is because these kids are already most often antibiotic exposed anyway from the start. And secondly, because it isn't necessarily a single organism, classic pneumonia type pathophysiology. So how does VAP develop? Well, VAP, the problem is that there's a number of reasons why organisms might migrate, because we have a lot of organisms in our GI microbiome and a nasopharyngeal microbiome. And when you're lying on your back, or even if you're lying flat for prolonged periods, there's likely to be migration from the back of the throat down the endotracheal tube. There's also likely development of biofilm and also, liquid and humidity at the top of the cuff, which might be a medium for sort of bacteria to grow. Positive pressure ventilation, patients aren't moving very much, not sitting upright and not moving around, which means there is a creep of gut bacteria into the lung. So that's going to happen to everybody, but not everybody gets VAP. So all of you, if you're lying flat, would have that same shift in your microbiome. Your healthy lung microbiome, there is likely a lung microbiome, but it's going to be quite scant, and probably largely it's just sort of a fairly clean environment that then starts to see some sort of enteric organisms coming in. But why do some people then go on to develop a VAP, and the only things that might come up will be a mixed culture of these gut pathogens? And that's because part of this is to do with inflammation. So of course there's a sort of there is the issue of edema, tissue edema. So you've got critical illness induced changes in your immune response too, and so your innate immune response might be dampened because of the sort of response to critical illness, which does cause initial inflammatory surge, but then you get a compensating anti-inflammatory response, and that's going to happen at about 2 days after, or a few days after the onset of critical illness. So the timing works that you're therefore potentially more vulnerable to secondary infection. But then what we see in the prevalence of pneumonia as it develops in the pathophysiology, is that the presence of a disordered lung microbiome might trigger local inflammatory response, edema, release of cytokines, and infiltration of more inflammatory cells, and as a result, cause tissue injury. But it's not in the same way, it's not a consolidation and a lobar pneumonia in the same way as a classic community-acquired pneumonia. So this type of pneumonia is a more complex beast. And this gives us the weighing scales that we're standing at the bedside. A child who was we know he or she is going to need a long period of ventilation, and then suddenly they start to go off from their respiratory point of view, and you're worried, and you're going to have a low threshold because we deal with severe infection or with very complex children, and therefore we give out the antibiotics. And the problem with that is, of course, that, as I said earlier, and this was data from our unit, that between 35 and 100% of days in PICU are spent on antimicrobial therapy with a median of 67. So antibiotic use is heavy. And as I said earlier, the pooled secretions, the fact that we're supine means that the bacteria can spread into the lung from the upper GI microbiome. So what is the prevalence of it? It varies, and we've done a lot of audits about it. 14% is probably at the higher end. It's sort of between 8 and 20 generally. 20% would be in certain groups. So I think even in adults as well. Interestingly, trauma and traumatic brain injury patients have a much higher prevalence of VAP than other types. And also, of course, some children who come in with a primary lower respiratory tract infection, viral infection, might go on to get a secondary VAP as well. And as I said earlier, it does increase your duration of ventilation significantly. So we had done some work looking at how the impact of and sort of what the current status is. And you'll know that in some sites, and there's a lot of sort of push for molecular diagnostics because the diagnostic yield is so poor with traditional culture techniques. So in patients admitted to our PICU, we looked at how often we were getting positive results. And if we look at the lower respiratory tracheal aspirates, you can see that, you know, in community-acquired pneumonia, you've only got a positive result at 17% of the time. And here it's 57. As you can see, the numbers are lower. It's only 7 patients. But cultures are not always positive. So therefore, we start the antibiotics because we're worried, and then we don't know when to stop it. And they don't always get better because it's an inflammation as well as a dysbiosis going on in the lung. So how can we make things better? And the thing that has been most of interest recently has been trying to use personalized medicine. And by that, it means we need to understand the disease better and then apply it to our patients at the best time for them. There was a big trial that was done in, it's led by UCL, but it was done mainly in adult units, but some PICUs as well. And I think it was about 500 patients, of which 100 were children. It's called Inhale, and they used a film array called BioFire pneumonia panel, which is a mix of common viruses and common bacteria, including the upper GI bugs and some atypicals, on a chip that sits in that goes in a machine that sits on the ICU. So it was very well liked, obviously, by the clinicians and nurses because you get an immediate answer. It has a turnaround time of hours rather than days. And what you do is you get your secretions, you put it on the chip, and you put it in the machine, and it spits out what the likelihood is of an infection. Now, it's not cultures, it's based on amplifying the molecular detection, the DNA of these bugs and you know, what is the genetic presence. So there's always a need to understand how to interpret the data, because it may be that, for example, as you know, when you've got a virus present, you might shed it for a long time, but it not be clinically relevant. And as I said earlier, you might have some degree of enteric organisms in your lung microbiome, but it might not be causing you an infection. That might not be the cause. So therefore, they did a trial. And what their trial did was to randomize patients on an individual patient basis to either standard care, which was using cultures and whatever this was normally done, or using the biofires alongside that. And what they also did was they had a pack that told you what you should then do with those results, i.e., these are the antibiotics we suggest you change to. They didn't make you change, but people did. So I know the results. It hasn't yet been reported. I'll tell you those. So essentially, they showed non-inferiority. What they're looking for was non-inferiority in clinical cure at 14 days post randomization, and superiority in antimicrobial stewardship. Now, they had definitely superiority in antimicrobial stewardship, but what they found was actually the clinicians did what they were told. They reduced the antibiotics appropriately, but then when they judged clinical cure, which is quite a subjective thing, and they realized that post the event, they showed that actually the patients who had interventions based on the biofire had slightly worse outcomes in terms of clinical cure. So it comes back to the situation of VAP is not straightforward. And so, yeah, so just we know these machines work. We ran a study here called Rascals, and I'll show you that in a second. Inhale looked at it as well. And what they looked at was correlating film arrays alongside traditional cultures and metagenomics. And they found very good specificity and very good sensitivity. So here we did one called Rascals, and it used an TaqMan array card, which what that means is that you put your sample in, and then it runs a PCR cycle, amplifying everything, and then each of these little wells has a little hole for capturing different pathogens, bits of different pathogens, to then see which ones are being detected. And the higher you have to amplify, the bigger the number, the less is present. So if you start detecting here, it means there's already a baseline of lots of genetic material, and that means a lower number means more likely infection is present. And people loved it. And as you can see, we had lots of viruses, we had gut bacteria, we had atypicals, including Coxiella, chlamydia. So you know, this was well liked, and it was effective, and we did it through the pandemic. So at one point we did actually add in SARS as well to that thing. And what we did was, as with Inhale, we split the sample, went to routine culture or on the TaqMan array card. And what we found was that I didn't want to go through the patient, sorry, don't want to bore you with this too much, but essentially what we found was that our patients, as expected, were little. They weren't too sick, but they had a range of things. It was patients with a suspected lower respiratory tract infection, either VAP or CAP, and as expected, most of them, vast majority, were of community-acquired pneumonia. And we did a lot of TaqMan array cards, and what we found is that obviously it was much more sensitive. So the blue is your standard test, along the x-axis all the different bugs that came up, and you can see that culture comes up, and where culture came up, the TaqMan array was matching it and finding it too, but it was finding other things. So good sensitivity and good specificity. And much faster. And this was not done on the unit. So the TaqMan machine was sat in the micro department and was only run 9 to 5, Monday to Friday. But despite that, the median time to get a result was 26 hours compared to 72 hours for routine culture. So it was faster for any result, positive result, from sampling to result, and from lab registration to result. Now, coming back to VAP, so that works, but the problem is, how do we implement it safely then? And what we know is that children who are ventilated for a long time do get this change in their microbiome. Now, this was work that I did, and we did full metagenomic sequencing. And this is looking at 3 samples from children coming into the PICU. And what we can see is that when they are admitted, when they're not had loads and loads of antibiotics for a long time, they've got streptococcus in their throat, micrococcus, and then a range of other bugs. And you can see lots of colours there, so relatively diverse. And you can see here that at the time of extubation, you've got a real widening in the in different bacteria, and in particular, we're getting things that start to have some antimicrobial resistance intrinsically, like Prevotella. But it does in convalescence, which we took was when they're on the ward, we did swabs, and you can see that actually things do tend to go back to normal. So the question then to ask is, what is going on in the lung in VAP? And as I mentioned before, there's two things. One is collapse of the fragile lower respiratory ecosystem, but also immune suppression, and then later on inflammatory changes. And talking of inflammatory changes, this was a really interesting study in adults where they did a range of tests for inflammatory biomarkers. And what they found was that certain cytokines, particularly IL-8, were highly sensitive to rule out VAP. So that if IL-1 beta and IL-8 were low, you definitely didn't have VAP. And this was so convincing that the NIHR funded them to a biomarker-based test called VAP Rapid 2, randomized control trial, telling clinicians, do this test. If it's negative, you stop the antibiotics. Well, what they did was they said the biomarker did work, but clinicians did the test, and it was 100% true because subsequently the cultures came out, but clinicians didn't. Clinicians went with their gut and did not change the antibiotics. So this trial was failed because clinicians' behavior didn't change. Because when you're standing at the end of the bed, if you see a sick child or adult with multi-organ failure, which viruses can do as well, you will still have a very high threshold for stopping antibiotics. You really won't want to. So this is the problem that faces us, which is how do we diagnose VAP? And there are lots of criteria. There are lots of sort of tables that you'll have seen, but it's really not bedside user friendly. So this is a sort of from a recent review talking about clinical pulmonary infection score, because diagnosing VAP, aside from the fact that cultures are usually negative, we're looking for changes in respiratory secretions, X-ray, radiology, and signs of inflammation in terms of white count, temperature, as well as ventilation getting worse. And this was an interesting thing, which was kind of a stepwise change in terms of how we think about VAP. We calculate the CPIS. If the CPIS is high or low, we would commence antibiotic therapy or continue investigations. If it's low, but we still have a suspicion, we will do our microbiology and chest imaging, and then consider whether we start or continue to review. And that's the kind of what we should be doing, but actually what we are doing is we're starting antibiotics. So these are examples of like the CDC criteria. And all of these are very good at telling you retrospectively this was VAP or this was not VAP, but actually often at the bedside things are not as clear and as black and white. So yeah, so if we think about treatment, well, obviously, if in the absence of multi-drug resistant bacteria, you should be choosing empirical therapy, but we tend to consider Pseudomonas a risk, and therefore we will tend to go for MDR therapy. So either we would normally use pip/tazobactam plus or minus an aminoglycoside. But obviously, if a patient is extremely sick, we may consider a carbapenem such as meropenem as well. You will know all of this, except that I wanted to ring this one, STD. So head elevation, inline suctioning, keeping the ventilator circuit free of water collections, obviously hygiene and sedation, vacations. STD, selective digestive tract decontamination, is controversial. There's been lots of trials in adults. We ran a pilot trial here, and there's likely to be a definitive trial for children as well to see, because STD is the one thing that studies seem to suggest reduces your risk of ventilator-associated pneumonia and reduces mortality risk. However, microbiologists hate it because what it is giving non-absorbable antibiotics to all patients needing mechanical ventilation for more than 2 days, and it's giving antibiotics that will get rid of your gram negatives, and it's non-absorbable, but obviously the worry is, does it lead to increased resistance? So watch this space on that, because that's the one thing that does work. There was a big trial reported, it's called Sudoku in the adults, that didn't show a mortality benefit, but a a systematic review subsequently published by that group looking at all the trials suggests there is a marginal benefit. I know the Canada trial is running and due to report soon. So it'll be very interesting to see where that goes. And we're likely to be doing a UK-wide trial as well. So what can we do better? I think we're planning a study to sort of look at how the microbiome and host factors might lead to that, by seeing if patients start phenotyping into different groups, because they're all of the patients ventilated for more than 2 days, only some of them get VAP. So when and what are the differences in their host microbiome interaction? Can we improve that, understand that, to get a personalized risk prediction? Can we use that risk prediction to either stratify them to SDD or other preventive treatments, or even to starting or stopping or changing antibiotics? But this needs to be rapid. And not rely on traditional culture-based or lab-based techniques. That's all I have. I hope. Sorry, I do speak very fast. Has anyone got any questions? Have you got any questions?